Welcome to ACR On Air, the official podcast of the American College of Rheumatology, where we have engaging conversations with leading rheumatology professionals on topics such as the latest research on rheumatic diseases, solutions for addressing practice management issues, legislative policies impacting patient care, and more. Here's your host.
Welcome back to another episode of ACR On Air, the official podcast of the American College of Rheumatology. I am your host, Dr. John Hausman. Show notes for this episode can be found at acronair.org. You can also find previous episodes on Apple Podcast, Spotify, and on your favorite podcast app. I'm fortunate to practice rheumatology in Boston, where there are more pediatric and adult rheumatologists in this city than there are in many countries around the world. For the most part, my patients have access to the latest drugs. I can routinely get any blood work or imaging study that is needed, and I have a whole team of nurses and pharmacists that help me make sure my patients get the care that they need. However, many countries don't have rheumatologists. Think about that. An entire country, 0 rheumatologists. As a result, it's likely that in these areas, rheumatic diseases aren't recognized. Or if they are, there's limited knowledge on how to treat them, or limited access to medications, limited access to labs, imaging studies, or even pharmacists that are comfortable in dispensing these medications. There may also be cultural barriers about having a chronic disease and needing to take medications regularly. Fortunately, there are people in the world that are trying to make a dent in this space. One of those people is Dr. Michelle Meltzer, the president and founding member of Rheumatology for All, an organization whose global mission is to provide rheumatology services in underserved areas, mostly working in developing nations throughout Africa. She's joining us today to discuss the global burden of rheumatic diseases and the organization that she created to help address these needs. In addition to her work at Rheumatology for All, Dr. Meltzer is Clinical Associate Professor of Medicine at Jefferson Medical College and a Senior Scholar in the Department of Health Policy. Hi, Michelle. Welcome to the show.
Thank you very much for having me.
So, Michelle, I wanted to ask you, how does someone from Philadelphia end up in Ethiopia?
Well, it's a bit of a story. I was in private practice and had a bit of a midlife crisis and decided to go back to school. So I went for a degree in bioethics. And while I was there was a mass email to the student body about a fellowship in global health. And they were giving out scholarships. And I was sitting next to my husband, and he said, there is no way that they would offer you a scholarship, because I was very much middle-aged at this time.
Very supportive husband.
Absolutely. So I threw in my name. I got one of the 12 fellowships, and I started the course. I had never really thought much about global health, much one way or the other, and my eyes were opened. And it was good because I learned not just about medicine, but about water, about access to good sidewalks, just a lot. And then I had the opportunity to go to Ghana as part of this fellowship. And while I was there, I was looking at pain management for sickle cell disease, which this was in the middle of the OxyContin push. So I was thinking I was going to tell them about OxyContin, but they told me that we don't really need OxyContin. In the meantime, I felt as a rheumatologist, we were at a big medical center. I would just volunteer to give a lecture in rheumatology. So I went in front of a group who I thought were medical residents who turned out to be pediatric residents and gave them a lecture on rheumatoid arthritis. And it was shocking. These otherwise very smart, excellent residents knew nothing about rheumatoid arthritis. And then I said, let me see your library. And there was not a book on rheumatology. And that's when I decided that something had to be done.
Wow. Do we know anything about sort of the rheumatic disease burden in developing countries, or, whether rheumatic diseases are more or less common in areas like Ghana or Ethiopia?
So the burden of global disease has done work looking at this. It is hard to extract some of the data because to get the data, you have to be able to identify rheumatoid arthritis, psoriatic arthritis. But we do know that of the major causes of disability worldwide, back pain and osteoarthritis are high up.
So you are in Ghana and people don't know about rheumatoid arthritis. So what do you decide to do next?
So I went home, and the American College of Rheumatology has our wonderful journal, The Rheumatologist. And I read in that there's a Canadian group who is doing work in Kenya. Also, in the middle of all of this, I got Indian doctor contacts me, and I think it's a hoax at first, that there's an article he would like for me to co-author from India. I just put him off and I ignore him. And then he's pretty persistent. And it turns out he's quite legitimate. And I do review the cases. We co-write a journal. It goes into a journal that's in India. And we start corresponding about different cases. Eventually, I said to him, I want to talk to you on the telephone. And he says, I don't talk on the telephone. And as bizarre as this may seem, I flew over to India to meet this guy. And I went to Bhopal, and he had a friend in Kashmir. And again, it's the same story. Very smart people. This Dr. Biswas is probably one of the most brilliant people I've ever met. And I had to help him on how to do a joint examination. So then I read something in The Rheumatologist about this group in Canada. I contacted them, and they had some contacts in Ethiopia, and they were planning on doing a continuing medical education course in Ethiopia. So we went over there twice and we did the CMEs. And what struck us was that the audience was extremely eager, but this was not self-sustaining. There's a reason we have to do a fellowship. So it was actually an Ethiopian man who I had met through some connections in Philadelphia, and his brother, who run a nonprofit in Ethiopia, took us out to dinner, and we were belly aching about how we didn't have enough money. We wanted to do so much, but we just didn't have funding. And he said, be quiet, form your own nonprofit. And that's how Rheumatology for All was formed.
Wow, that's amazing. So at that time, is there any rheumatology training in places like Ethiopia or Ghana? Or are there rheumatologists in these countries? Or do people with internal medicine background sort of are the ones that are supposed to manage patients with rheumatoid arthritis and gout and things like that?
So it's spotty. Ethiopia did have a rheumatologist many years ago. And what happened is when the AIDS epidemic started, he was the closest person to a immunologist that was in Ethiopia. So he left rheumatology and ran their AIDS program. So he started a rheumatology clinic, but then he left. And one of our board members, Ewan DeWosen, who's a nephrologist, then ran the rheumatology clinic for many, many years. So many of the countries don't have rheumatologists. It turns out since I left Ghana, Ghana now has a rheumatologist who's very good. There's still very few. So because of Rheumatology for All, there's now 2 rheumatologists in Ethiopia, and that's a country of 110 million people.
Oh my goodness. So how did you go from this idea to actually creating rheumatology for all? And then what did you decide to focus on, given there's so many issues, so many needs to address rheumatic disease in these developing countries?
So, what we thought was that the best thing to do was to figure out a way to train local physicians to become rheumatologists. Then they can train other physicians. They can also advocate and eventually form a freestanding fellowship program. And then they're on their way. So the local physicians identified two people, and then we started raising money. And it was challenging in the beginning because we didn't have a record. But we were very fortunate, again, because of the rheumatologist. I got written up, and the Arizona Arthritis Associates, one of their members, read the article and made an extremely generous donation. I also started speaking at the Rotary Club, and I got a lot of support from, basically, if you talked to me, if you went out to dinner with me, you had no choice. You would hear. I mean, I was out. I mean, I was kind of nice, but everyone knew what I was doing. And some people were kinder than others. And we got donations. And then one of our board members is Girish Modi. He's in Durban, South Africa. And our idea was to train people in Africa. One of the things that we noticed that, especially me, because I'm at Thomas Jefferson University, it's an academic center and a United States hospital, and I have access to everything. And if you trained at Jefferson, you're not equipped to practice in Ethiopia. And the other reality is the infectious diseases. So I saw more people with tuberculosis in a week than I would see in my entire career here in Philadelphia. And so by training in South Africa, they are equipped for the local realities in Ethiopia.
That's so interesting. I remember I did a rotation in Durban, South Africa. And yeah, the inpatient ward was basically tuberculosis and HIV almost exclusively. And any complications that patients had, whether it was arthritis or pericarditis, was usually related to an infection. Whereas here in the US, our septic arthritis is much less common than some of the other types of arthritis that we take care of. So it sounds like you were raising funds. And was that the missing ingredient in Ethiopia, that they needed funds to help support somebody to do rheumatology training?
Well, yes. And I think it's also, they don't know, if there's no one there, they don't know where to go. I mean, you don't just meet a rheumatologist in South Africa. You need someone to kind of put the two of you together.
Got it. And there's a formal rheumatology training program in South Africa?
Yes, it's very good. So one of the, and this brings up the tragedy, is Joran de Woesen, again, who is one of our board members. He's a nephrologist, and he said it just was so hard on him because he would have these young women come in with lupus. I mean, the mortality was extremely high. And then he was running the rheumatology clinic without knowing. I mean, he did the best. He actually did a good job, but it was difficult.
Yeah, I can imagine, without also the resources. You were mentioning practicing, that it's probably different to practice rheumatology in Philadelphia than in Ethiopia. Also, I imagine because of, the absence of monitoring labs and things like that, and the absence of medications, right?
So this is where having a local physician is important. Unfortunately, because of the pandemic, I have not been there since the pandemic. I'm going to go in April. But prior to the time, Becky, in Ethiopia, you go by one name. So I'm calling them just by one name. But Becky and Berhanu, who are the two rheumatologists, they were able to get rheumatology recognized by the Ministry of Health. So because rheumatology was not recognized, access to methotrexate was very difficult. So there's a list of medications which are available, and methotrexate was listed only as an oncology drug. So if you were on methotrexate, you might be on it for 2 or 3 months, then you would miss a few months, and then you could get it again. And the first time we went to Ethiopia, we couldn't believe that the access was such a problem. So we actually posed as patients and went to a few pharmacies asking for methotrexate. And, we were paying cash and the whole bit, and we couldn't get it.
Okay, so Rheumatology for All sponsors these two physicians to get training in rheumatology in South Africa, and they come back to Ethiopia. Do they set up a rheumatology clinic, or how do they organize their work?
So they have been there now for 2 years, and we are so excited because about 3 weeks ago, the Department of Medicine at their hospital recognized that gave them its recognition of excellence award as being the section of internal medicine that's contributed the most to the training program. And there's people already who are interested in going to rheumatology. They've done an excellent job. The hope is, like I said, is eventually that they will start a fellowship program. They've only been out for 2 years. We also have 2 more people in the wings. We're sponsoring a pediatrician from Addis Ababa, and she's going to go to South Africa as well to be the first pediatric rheumatologist in Ethiopia. And we're also going to sponsor a Rwandan internist. He'll hopefully start at the end of the summer, and he'll go to Durban, South Africa as well.
That's amazing. So it sounds like Rheumatology for All is really picking up its pace in being able to sponsor local physicians to get training and then go back to practice as a rheumatologist. And I think your idea that this will be self-perpetuating, right? That the people that are there will create interest in rheumatology and then have other people, want to get additional training. It sounds like that's already been happening.
Yeah, so it's happening. And then we did another aspect is we started a visiting professor program, and we went to Ethiopia. We divided a month up into 2 weeks because it's hard for someone to take a whole month off. And we didn't choose, the locals chose about 5 medical residents, and we just did an intense program. They had protected time with us for about a month, and we saw patients with them. We had them give talks, we gave talks, and it was very good. And then we had the pandemic. But also, we stopped going to Ethiopia because now we have 2 physicians there and they don't need us. So then we started a virtual rheumatology program in Rwanda. And we were actually going to do it live. We're supposed to go the day after the world closed. We just missed getting stranded in Rwanda. So this is our 3rd year of doing a virtual program. And when we got our assessments, the one thing they didn't like is they said that we didn't get to do hands-on. So in April, we're going to go there for a week and do hands-on, but we're continuing with the virtual lectures. The program's about 6 weeks. And one of the things that we've done is to have African rheumatologists as well as Western trained rheumatologists as our speakers.
That's amazing. So it sounds like what Rheumatology for All is doing is enhancing rheumatology training across low-resource countries throughout the world in both giving educational lectures, but also sponsoring people to get further training in rheumatology. That sounds incredible. I wonder, you mentioned about virtual lectures. I wonder if there is a role for telemedicine. Have you been able to incorporate virtual visits or anything like that, trying to help the local rheumatologists provide rheumatology care to their patients?
Well, right now we just have the 2. And one of the things I have an advantage over them is I have an excellent library. So every once in a while, will ask for a resource. And I think Our board member, Dr. Modi, was one of their trainers, and I think that they will occasionally call him for advice. But they have good training, so I don't think that they need the telemedicine. The telemedicine would be extremely difficult. One of the problems or issues that we had there is, I mean, first of all, we weren't licensed to treat patients, but we did see patients that you had the language barrier, but there's also a cultural barrier when dealing with some of the patients. I think a lot of them don't have the funds to get medications, some of the family dynamics. I think that the best thing for us to do is to train people who know what the local situation is, and then to be here to offer advice if they need it.
And what barriers has Rheumatology for All encountered in this process? Because it sounds pretty complex, and what you're trying to do is incredible, but I imagine that it's not easy.
Well, the finances were the first one. Getting started was difficult. I did not mention another source was the Canadian Rheumatology Association has also been extremely generous to us, in addition to the Arizona group and to other individuals who've been supportive. It's being creative. It's figuring out how to do the virtual program, getting a learning platform. It's all been a challenge. I spend hours a day maintaining the website. It's all a labor of love.
Sounds incredible. I wonder, we spoke a little bit about methotrexate, that even methotrexate seems to be challenging to use, although that seems to be improving. I wonder about access to other drugs. We can start talking about things like hydroxychloroquine. That may be simple.
It's not simple.
No, biologics, I'm sure that's very complex.
So they don't have hydroxychloroquine. They have chloroquine, which, as you know, is a little bit more, has a potential to be more toxic. We did some research looking at guidelines for the use of methotrexate. We have the guidelines, of course, from the American College of Rheumatology, but it's not so simple there. So remember, tuberculosis is rampant. So you have to understand, is that going to be a problem? Communicating methotrexate in pregnancy can be, again, that's a cultural issue. And that's something that, again, the locals are better to deal with. It's expensive to monitor people. We did some research. Maybe you don't have to get both transaminases. What's a minimal amount of lab you can get? So even methotrexate can be an issue. The patients have to come. Some of the patients are in rural areas. You're not doing telemedicine there. How often do they come back? One of the things we did too, it's actually a cute story. One of the times when we were in Ethiopia, the other members of my group went to church. I didn't go. And while they were in church, there was a group of people, and it was Inez Magna who's started with us. And she's very loquacious. And she said, "Oh, who are you?" Well, they were pharmacists. There was a pharmacist convention. So she met up with them, and she made up a questionnaire to ask them about their comfort level with the use of methotrexate. So these are pharmacists who were actually coming in for a convention, and they were pretty uncomfortable. And there are things that can happen, like let's say you're going to get your methotrexate and the pharmacist says, "Whoa, you have cancer. I didn't know you have cancer." So one of the things that I would say challenges, one is patient education. And it's more than patient education. You need to do pharmacist education, nurses. There's a lot, community healthcare workers.
So it sounds like certainly you've had some successes. You spoke a little bit about the challenges. What do you envision for Rheumatology for All 10 years down the road? What do you think, sort of the mission going forward, and what would success look like?
Well, success would look like that you don't need us anymore, to tell you the truth. So we have been, I'm not going to go into it now, but we have been approached by other areas. And it's the expansion. It's even where to send people. I mean, Hopefully, we'll have the program in Ethiopia. There's just so much capacity in South Africa. So it's looking to see where we can send the people. And hopefully, like I said, is that eventually there'll be self-sustaining programs. But even here in the United States, look, we have a terrible shortage of rheumatologists here.
Yeah, we do. Yeah, and pediatric rheumatologists in many states are few and far between. How are you measuring success? Do you have a process of tracking outcomes, or are you involved in research, to show sort of the impact that you're having in these countries?
So what we did is we did an audit of the rheumatology clinic when we first got there, before the two rheumatologists came back. And we just randomly picked 50 patients and looked to see what medication they were on, what counseling they got before receiving methotrexate. And then our idea is to do another audit, again, randomly choose 50 patients and see how things are going. It's difficult to measure we don't have other good ways to measure success other than the actual people being there. And that's something that we've thought about, but I guess there's just so much energy. But the audit will be helpful. And one of the things that we found on the initial audit was the use of corticosteroids. So remember, you can't have difficulty in getting methotrexate. Some people are on chloroquine, but you have someone with very active rheumatoid arthritis. And unfortunately, we saw some people who had been on corticosteroids for many, many years. And I think that would be one of our measures, is if we can see a decrease in the use of corticosteroids. And the other, if we could do something, would be to seek to get more biologics. But even biologics are going to be an issue because of the infections.
Yeah, I mean, even here, obtaining biologics is challenging. They're pricey. You have to refrigerate them.
Well, the refrigeration is a huge issue too, because there is a middle class population that is there. And the last time I was in Ethiopia, I was talking to one of the gastroenterologists, and they do have biologics for the private patients for inflammatory bowel disease.
I wonder about musculoskeletal ultrasound. That's becoming more common here in the US. And now there's these portable machines that, you could put on a patient and, get an answer as to what's going on in the joint. I wonder, have people in these countries been trained or have access to musculoskeletal ultrasound?
I'm actually not sure if Becky and Brahano use it. I know when I was in Kenya a few years ago, they were using the ultrasound, but I don't know what they're doing in Durban. But yeah, I don't know.
Sounds like potentially that'd be a great option. Michelle, how do you juggle rheumatology for all and your clinical practice? How do you make it work?
I'm old. I'm old. So what I did is I basically just work a few hours a week at Jeffers. They've been very, very kind, because I need to work to keep up with with what's going on in rheumatology. But I spend hours and hours a day doing this. So that's how I do it.
An act of love, it sounds like. So how can listeners get involved? I mean, this is so interesting for me to learn about sort of the lack of rheumatology in places like Ethiopia and Ghana. As a medical educator, this is certainly right up my alley. But how can listeners get involved in Rheumatology for All, or in trying to address some of the issues that Rheumatology for All is targeting?
Well, one is donations. The other is creative ideas. And actually, I think you're one of the people years ago that I started looking at Twitter and different means like that. So actually, I've prepared a very short slide presentation on how to use social media to keep up. I'm going to Ethiopia, and I didn't want to do something didactic. I don't want to take away from Becky and Berhano, and I'll use that in other places. But if people have ideas, the problem with some medical education is asynchronous, asynchronous, and you can do webinars until you're blue in the face, but you need something that's interactive, and you need a lot of people to do that. So we're looking at ways to expand our virtual program, but you've got time zones. I mean, when I give my lecture, I'm doing it at 6 a.m. Philadelphia time, to do it at 1 in the afternoon in Rwanda. But if you want to have more than one group of people on the same lecture, how do you do it at the same time? What's too many people? So it's creative ideas on how to expand an interactive program, because in the end of the day, our lectures are good, but the discussion is really key. That's what we're trying to figure out. Anyway, people who have creative ideas in medical education, I guess, is what, and then donations.
And it sounds like also the hands-on, right? Like how to examine a joint or how to actually manage a patient would be incredibly important.
So we actually made a video. One of Andres Ponce, one of the rheumatologists at Jefferson, and I made a video on how to do a joint exam. And it's difficult because if you make it too detailed, you'll fall asleep. And if you make it too quick, you don't do anything. But they liked our video.
And Michelle, we'll certainly put links to Rheumatology for All, at the ACR On Air webpage so that listeners can get more information and certainly donate. It sounds like an incredible cause. I'm so happy that by chance you became interested in global health and landed up in Africa to try to address some of those needs. It sounds like Rheumatology for All has really made a difference so far. And, I can't wait to hear what happens 5 or 10 years down the road where, as you said, maybe they won't need you anymore.
Yes, that is a mark of success.
That's incredible. Well, Michelle, thank you so much for your time. This has been very enlightening. I encourage everybody listening to take a look at Rheumatology for All and certainly learn more and donate. And certainly we can also put you in contact with Michelle if you'd like more information. Thank you, Michelle, for your time.
Jonathan, thank you so much.
Thank you all for listening, downloading, subscribing to our show, and for rating us with 5 stars, or however many stars you think we deserve. You can find all our show notes for this episode at acronair.org, as well as in Apple Podcasts, Spotify, and on your favorite podcast app. Until next time, save the world, donate to Rheumatology for All, and of course, stay healthy.